Hi everyone. Hi everyone. Can you hear us?
Yeah, yeah.
Uh,
Hi, Kevin.
hi. Welcome to this month Pandemic Preparedness Working Group webinar. But this gonna be an interactive webinar. Would be a bit different, less lecture, hopefully, and a bit more discussions. And we have amazing people here. We even have amazing people from the WMA Junior as well supporting us. So thank you so much, Grace and Pablo, for to be here. I see a lot of familiar people, so thank you so much for coming as well. And thank you so much for sharing this sessions. So we will just start right away. And this webinar is called From PHEIC to Preparedness, Frontline Doctors Community Trust and Africa-led Outbreak Response. So we will try to learned about what's happening about the outbreak, and I will let you know a bit of the history of why we are trying to do this. So this idea comes around the Andes strain of the hantavirus outbreak a couple of months ago, which was very concerning. This happens, I think, right after our JDN spring meeting in Serbia, and MC and I were discussing, let's do something about this and try to make people learn about what is pandemic preparedness. Because one of the things that we learned through the spring meeting is that some people, junior doctors especially, feels that um, they are not well equipped and they do not know, and that's why they do not want to engage. So the most important thing is capacity building and understanding a bit more about what we are actually doing, and also learning together, sharing, building the community. Junior doctors, we have a lot of energy, and we also have this space. We have a very senior people, very experienced people who have work on the ground, who is actually doing outbreak preparedness and responses, and we can learn from them as well. And this is the idea. And after that, it kind of changed a bit and reshaped, because we changed it from hantavirus outbreak focus towards a bit more Ebola, because that's the one who becomes a PHEIC. And if you do not know what is PHEIC, it's okay. We are here to learn together. And this would be our agenda for the meeting today. And there would be five-part introduction with opening, technical and policy update with Dr. Aggrey. There will be a bit of presentation discussions. MC will be moderating that. So feel free to engage through anything, through chat box, unmute your mics if you want to, or if you can give a bit of like emojis or reactions, anything. And after that, we'll have a bit of frontline roles and health systems, and this is designed for a bit of like reflection space and interactive discussions. There will be some guiding questions, and we are joined as well somebody from RANA, Anthony, for a bit of like interesting discussions on equity and community trust and what does it mean. And the last part is closing. So yeah, so the introductions and opening, and this there would be two moderators today, and I haven't officially introducing myself. So my name is Kevin Alvaro Handoko. I'm a medical doctor from Indonesia. I am serving as a co-chair Pandemic Preparedness Working Group with Mary Claire Wangari, or MC, as she like it's very cool to call her MC. So MC will be helping and also moderating some part of the discussions. We are very excited to welcome you. And today we are also joined by the SM panelists, Aggrey Aluso. And Aggrey Aluso is a executive director of the Resilience Action Network Africa and the global policy lead for Resilient Action International, or RANI. He currently leads RANA operationalization across Africa to deliver its mission as lead convener as a cross-sectional CSO advocates, driving Africa-centric, globally facing resilience agenda that encompass the interconnected issues of pandemic preparedness and response, climate change and its impact on health, as well as galvanizing and enhancing Africa's influence in global health governance agenda. He previously worked as a senior manager at the Open Society Initiative for Eastern Africa, leading the Health and Rights Program, and later leading then OSF Africa COVID response. So he's very equipped for this. And additionally, he served in senior roles at various reputable INGOs, including Preparedness as the technical expert lobby and advocacy at the University of Manitoba Institute of Global Public Health, attached to the then NACC, leading the key population advocacy and policy development. He's a seasoned social justice advocate with expansive experience spanning over 20 years in advancing intersectional justice. And we are also joined by Antonio Mbara, which is a senior policy lead, I believe, from the Recent Action Network Africa. And thank you so much for the panelists for joining us. But before we start, I would love to start with this discussions, of course. Please feel free to join in, unmute your mic or chat box. I will be helping monitoring them. So we have known that there has been recent outbreaks. There's a lot of things, for example, the COVID PHEIC or pandemic that happens from 2019 to 2023, such as Mpox. There's also Nipah virus, and the virus that is also multi-country linked to cruise ship. There's measles outbreaks that happen due to vaccines in Bangladesh and USA a couple of months ago and last year. The recent one that becomes PHEIC that happens in DR Congo and Uganda, which is the Bundibugyo strain of Ebola virus. And right now, if you heard everywhere also in the news, is the Cyclosporas explosive diarrhea outbreak that is happening in the USA. So there's a lot of outbreaks happening all the time. You can see even in the last 1-2 years, there's a lot of things, and this will be increasingly. This will continue increasing, like the prevalence, and also hopefully not. But it's not about the next pandemic will happen. It will happen, but will we be resilient enough to be able to respond to that? Are we equipped enough? And that's the question. And that's why this particular discussion is needed to happen, for us to learn and build our competencies and a bit of reflection, so we can also be a bit motivated to learn by ourselves. What can we do in our community to help to curb the outbreak and help on the response? The first question is, why is an outbreak important to my health system? Why do you think an outbreak is actually important for your health system?
Is that a question to me, Kevin?
It's a question for everyone, especially the participants.
Oh, okay.
You can.
Thank you
Yes,
so much. All right.
You can also answer it in the chat, or you can also unmute your mic, please. Like, there's nothing wrong for this. We just would like to see what's your opinion on this. Yes, Amira Amrun.
Thank you. I think there are two main perspectives. One from a general practitioner, because all the health interventions and the infrastructure goes into chaos. It becomes an immediate priority, I guess, and it disrupts what we call normal course of healthcare. But it also makes us learn about the system. And if we think from a public health perspective, it's a problem, because it tells us already that we maybe bypassed some important steps in maybe, I don't know how to call it in English. It's like the surveillance failed at maybe prevention and also early intervention. So if we have an outbreak, that teaches us a lot about where we failed and maybe where work should be put coming forward.
Thank you so much for engaging. And yeah, and as you said, like you mentioned about the health systems and how that prepared the preparedness response is very important, as we, our junior doctors, are the first line in command to prevent them and to be able to respond them firsthand, to be able to notify. So it's important for us to learn, and why an outbreak is important. It's because of that. And I see there are several people who are engaging to the chat. Thank you so much. I'll be reading them. Luca said it helps detect vulnerabilities of the health systems and where we need to act better prepared. Kieran said because it tests the ability of the health system to respond. Very good. Anthony said an outbreak exposes or tests the health system. It makes hidden weaknesses visible. The true measure of resilience is not simply whether the outbreak ends, but whether the system and its relationship with communities emerge stronger. And Rahab said, it stresses the health system, increasing demand for health system resources, and may expose weaknesses in preparedness and response. And last but not least, Zara said it can instantly overwhelm hospitals and healthcare personnel, ranging from knowledge to resources. So basically, we are part of the system as junior doctors, as people who are in the front lines, and how we need to understand this and how it relates to our health system, because it is us, it is part of our work, and we are the one who will be responding first and foremost. And there's a lot of maybe confusion, or not, maybe a bit of not understanding enough the difference. What is outbreak? Is it PHEIC is different? Is it pandemic is also an outbreak? What does it mean? So I will try to give a bit of introductions, just to everyone caught up with this term. So I think we all received this during our public health rotations or public health modules during our medical schools. So an outbreak is a disease occurrence above the expected level in a particular population, location, or period. And this is from CDC. So for example, for a given time within 2 weeks, or within the season, for example, within a specific location that links by institutions, affiliation, exposure, or small geographic area. For example, does it happen in a country, or does it happen in a nursing home, or happens just in a hospital? What does that is a operational definition of an outbreak, or for a target population such as students or long-term care residents. So there are when the disease, especially infectious disease, increase above the expected level in a particular population location period, we can call them an outbreak. For example, if there's no case at all of dengue and there's suddenly one case of dengue, is an outbreak or not? It actually depends on the area, period, and population. If, for example, I used to work in rural Bali, dengue is such a normal case. For example, if it's basically where the time the dengue will spike, then we won't call it an outbreak, because year by year, it's always been like that. The cast pattern is it's followed the cast pattern. But if suddenly everybody got a dengue when there's supposedly no dengue, for example, if there's dengue in Norway or Iceland, then it's something that we need to think about what's happening. Or in Italy, for example, with climate change, now mosquito can travel further and further north. So in a country that are in the past, maybe they don't have mosquitoes to transmit dengue, now they can transmit dengue. So it's based on the population, the location, the period, and it differs by definition and by disease as well. And then what is PHEIC, which we'll be discussing a lot, which is public health emergency of international concern. It's actually a formal legal designation under the IHR on international health regulations. It means that there is an extraordinary event that risks international spreading and may require coordinated international action. That's the part that is very important and very distinctive. It's a very special kind of outbreak. And it could be deadly, even though it doesn't become a PHEIC, but a PHEIC only can be declared by the WHO Director General, advised by the Emergency Committee, and with information and consultation with member states that are affected. And according to the IHR definition, it's an extraordinary event, which is that determined to constitute a public health risk to other states through the international spread of disease and to potentially require a coordinated international response. This definition implies a situation that is serious, sudden, unusual, or unexpected, carries implication for public health beyond the affected state's national border, and may require immediate international action. So that's what's different. And what about pandemic now? That's happened because COVID becomes PHEIC first and then become a pandemic. A pandemic is just simply that there's a worldwide spread of a new disease. And for an influenza pandemic occurs when a new influenza virus emerges and spreads around the world. And most people do not have immunity. Viruses that have caused past pandemics typically originated from animal influenza viruses. It could be COVID, respiratory disease. It could be other infectious diseases as well. It doesn't have to be just influenza. That's an example. So yeah, the next, I hope that I caught you up to speed about the terms that we'll be using a lot, and we'll be moving a bit towards the technical and policy update and discussions. And I will give this presentation space and this discussion space to MC to moderate and Dr. Aggrey, and I will share the PPT.
Right. No. No.
Can you see the screen, Aggrey?
Oh, sorry. I don't know. I can't see the screen. Can you hear me?
We can hear you,
great.
yes.
No, okay, great. Sorry, for a moment I lost my screen there and I was like, oh, am I cut off or not? So apologies for that. So thank you so much, Kevin and team. Am I waiting for MC to introduce us? So over to you, Mary Claire.
Thank you. So for this particular session, we are with Aggrey Aluso. As earlier introduced, Aggrey is, just give me one moment. Yes, so Aggrey Aluso is currently with the executive director of Resilience Action Network Africa and the global policy lead of the Resilience Action Network, Action International, RANI. And he currently leads RANA operationalization across Africa to deliver its mission as a lead convener of cross-sectional CSO advocates, driving Africa-centric, globally facing resilience agenda, encompassing the interconnected issues of pandemic preparedness and response, climate change and its impact on health, as well as galvanizing and enhancing Africa's influence in the global health governance agenda. He previously worked as a senior manager at Open Society Initiative for Eastern Africa, leading the Health and Rights Program, then later leading the OSF Africa COVID response. Additionally, he served in senior roles as various reputable international NGOs, such as Trade de Home, as the technical expert lobby and advocacy, and at the University of Manitoba's Institute of Global Public Health, attached to the then NACC, leading key population advocacy and policy development. He's a seasoned social justice advocate with expansive experience spanning over 20 years in advancing intersectional justice. And today he'll be taking us through our expert discussion on from PHEIC to Preparedness, Africa-led Outbreak Readiness. Over to you, Mr. Aluso.
Thank you so much. Thank you so much, Marie-Claire and Kevin, and dear colleagues from wherever you're joining from. It's a pleasure to join you today and to share with experts who I'm sure are very well knowledgeable about the subject matter more than me, because you are doctors. And what we do as those who are working from civil society side is to see how we can complement the technical expertise to bring into the space, the community dimensions, which are very critical as well, particularly when it comes to pandemic PPR. As many of you may have had a lot of observations and sayings, pandemic starts and ends in communities, or outbreak starts and ends in communities, which means the efficacy of our response, I think, is greatly influenced by how well our communities are aligned and are supporting our initiative. If you have efforts geared towards, detecting and containing outbreaks that are not involving communities, I think we always end up with interventions and countermeasures that are not, utilized, and of course that are therefore not effective, because it's only as useful. Any medical innovation or intervention is only as useful as its utilization, and the person who ultimately uses it is the community. And more importantly, if you can just move the slides along as well, more importantly is how do we build a system where the community, the formal systems and the informal systems that are community-led are working in tandem and that are complementing each other, and not just one-sided relationship where the technical experts like yourselves are generating information, generating countermeasures, and expect communities to just be consumers of those without their active and meaningful involvement. I think we've seen recent scenarios like what is currently, being witnessed in DRC, where we've witnessed some of the unexpected scenes of resentment and sometimes even violence, against people protesting against public health measures to help contain the outbreak. Who is moving the slides along? Is that you, Kevin? Yeah, just move them along. Move them along. Yes. Yeah. So we will talk about the dimensions that are not technical. I think I have to put a disclaimer that for us who are working from the civil society advocacy side, we are complementing the technical side. And I think Kevin did a very wonderful job taking us through the, taxonomy and all the technical, framing around what constitutes a PHEIC, what is a pandemic, what is an outbreak. I think those are standard definitions, sometimes political though, because the declaration of a PHEIC has been a subject of a very protracted, conversation. The question of when do we need to trigger what level of response, I think, is something that is very critical in determining how well we respond to it. So if we wait until we have a disease spreading typical to the previous definition, that it needed to be reported in a number of WHO regions before it can be declared a PHEIC, by the time it has left one boundary to the other, maybe it's out of control. Maybe it's late level of triggering the next level of action. And I think we have to also interrogate and probably engage in the discussions around what would be the best time to trigger what level of response. And I think there's been some progress in that line with Africa CDC, for example, initially triggering, a highest level of response for Mpox previously and the Ebola recently, when it's just within one country, because they could see the trajectory of the outbreak and seeing this is definitely going to spread out of control unless we trigger the highest level of response as soon as possible. And I think that's something that I think will inform the next iteration of global health policy reforms, including the IHR and the ongoing pandemic, agreement, which is still under discussion. So really, the conversations that we are going to have is, beyond clinical care, what are the imperatives? And how do we build on community trust? And my colleague Anthony will take some of those. And of course, we will expect to hear from you. Where do you see your role as people who are offering this services and working closely with communities. Beyond yourself, your other counterparts who may not be as, technically endowed, but critical because they are in the front line of the communities. How do you work with them to build a trust, to build the connectivity between the formal, which includes doctors and clinical clinicians working within the formal health system, to those who are engaged on the informal side or the community front lines, who are the first one probably to see any deviation, in terms of changes in symptoms being reported or clinical presentations. How do we work with them so that we're able to have the fastest response possible? Because I think for us, scientifically, it's been proven our best bet to containing an outbreak is the quicker we're able to detect an outbreak. And of course, you may be aware of the 717. I don't know whether you're aware of 1717 by a show of hands, just if you know. And the first 7, which is the time it should take, minimum time or the maximum time it should take before a new outbreak is detected, I think is really very dependent on the community systems. And it's really dependent on the connectivity and the level of awareness and intelligence that we're able to gather from the impacted groups. I think that is what would make a very big difference if communities trust the systems, are tooled enough, and are able to see that there's something different and report it within the shortest time possible in under 7 days. I think that would make a huge difference in terms of us being able to roll out the interventions to contain or to start, measures that would help us contain this outbreak before it spreads out of control. We've seen the impact of that not happening when outbreaks, spread within communities for long. It becomes very difficult and expensive to control, but also very, very impactful. Like today, you're hearing the Africa CDC Director General saying we've lost thousands of people, already more than 1,000 people to Ebola. That is the confirmed cases. We have a probability that it could be much more because there are systems that depend on reporting sometimes, and where there's lack of trust. Sometimes there are what we call secret burials or people not wanting to disclose information, and we may not know what we are dealing with if we don't have communities who are able to be open and support, the official statistical collation and collections. So, and this is happening in a context where we don't have the luxury of peacetime. I think what we used to call the interpandemic and peacetime are things which it's debatable whether there really has existed peacetime since COVID, because as you recall, as Kevin was enumerating the different iterations of outbreak we've dealt with, it was from COVID. Within the COVID period, we had an Mpox one that was declared a PHEIC in 2022. We had Mpox 2, which was declared a PHEIC in 2024, with the epicenter being in DRC. And now we have another PHEIC in 2026. And of course, it's happening in the context of continuing other outbreaks. We have nearly continuous outbreaks of cholera within the Eastern and Southern Africa. If we speak, there's a meningitis belt in the DRC, the Great Lakes region. So there's never been what we can call a peacetime or interpandemic. So this is really a different time we find ourselves in. And it's really something that requires a different approach. It's not just people in the health sector, because all these challenges are emanating from the multiple, dimensions that we are exposed to. It's a food system issue. It's an environmental issue. It's a climate change issue. It's a governance issue because and security issue. If you look at the challenges we're facing in the DRC region, and the frequency of outbreaks have actually been identified to be as a result of the fragility in that country. So if you're talking about people, frontline responders that need to help us keep our communities and the world safe, it's not just the doctors, it's not just the health workers, it's everybody else who need to work at the intersection of all these structural issues: security, food system, climate, financing, because the challenges we face are also financial nature. We have financing models that are not responsive to the challenges that we are facing. We have policies that are not aligned to the kind of challenges that we are facing. communities have struggled to even gain polity recognition as critical players in managing our health security. Just recently is when some countries have started recognizing them and formally recognizing them within the policy frameworks that they are also participants in these and critical actors as frontline providers of health intelligence. So really, community system intelligence is something that very, very critical. And integrating this with the the informal and formal is something that needs to be built as a coordinated, integrated platform that is built on trust and seamless synergy between the two sides, so that whatever is being reported from communities utilizing the technological advancement that we have can be reported in near real time, so that we can shorten the time of reporting within the first category of the 7 in the 717 ambitions. And of course, critical is the issues of learning and accountability. What we keep saying is that every outbreak should leave us better prepared than the next. We should be better prepared now. Every iteration of outbreak should be a learning point. And I like your questions. Kevin, the first question is, what do outbreaks tell us? They actually test our system. They should be learning points. Every time we've gone through an outbreak, I think we have the after event reflection. We should evaluate how did we not achieve the 7 target of detecting an outbreak within these first days, within less than 7 days of its emergence, and try to identify the bottlenecks and identify mechanisms of unblocking those bottlenecks, so that the next iteration we are able to get better in terms of quick reporting, quick detection and quick reporting and quick deployment of response. So I think that's very, very critical. So in terms of how we progress with this going forward, I think as it's been said in many contexts, the system that we built, and I'm still reiterating, it's a system that needs not to be built just during the outbreaks. It's a system that needs to be built continuously. Will help us be able to tap onto the signals and continuously be able to provide intelligence and the appropriate resource for our surveillance capabilities to detect if there's a variation or something that changes within our health system or health experience. So you people being in the health facilities, and I think one of the things we've been trying to advocate for, like everybody within the health system is a source of very important surveillance. The pharmacists, who will see a number of people buying similar medicine all of a sudden, all of a sudden there's some unexplained surge in the demand for flu medicine or fever or febrile diseases medicine, or diarrheal diseases medicine. People are not trusting to go to hospital, but you can be able to see something is changing. Schools even, where children present with similar symptoms over time, and you're able to see all of a sudden there's something that seems to be spreading within this community. Like 5 children are not in school. Those are essential potential sources of intelligence that can help us see that something is going wrong, and we can use that kind of information to help detect early and signal very quickly to the relevant authorities that something is amiss. But that can only happen if we have built that system, if we have created an integration and created trusted pathways that will channel this information and create platforms where people know that if we see this, then it could mean this, and we need to share this with this authority, and those authority will respond. There's a complete feedback loop and recognition of what is being reported, because if you report and you never get feedback, you never get acknowledged. Also, people get frustrated and lose trust in the system. Sometimes the reporting can lead to people being punished, even at the micro level. We know about South Africa's situation with the Omicron virus, variant reporting, and the global, response, which was isolate. It also happens in our local level communities. We need to not create systems that do not recognize and appreciate those kind. We need to reinforce those kind of positive support that come from our community. So really, that whole continuum is something that we need to build collectively, and not having those hierarchical barriers of I'm a doctor, I cannot receive information from a community health worker. I think we need to find ways of breaking down those barriers, and even you as a doctor, being able to go back and ask about where the people are coming from. Like, is it only you? There are other people who have this kind of symptoms. I think we have to go out of our normal clinical ways of doing things in this era of pandemics, because you're the first point of response. Maybe the one person who managed to reach you is just because they are privileged. They've left people behind probably who did not have the opportunity to do that. And you need to be proactive enough to find out from them how people are doing. I don't know how many of you as doctors usually ask questions about, how are people at home? No, it's an African thing to do. But I think when sometimes we get too busy, we lose that human touch. But I think we just need to get into that. And of course, as I mentioned from the beginning, I think that one of the biggest obstacles is our systems not being nimble enough and flexible to see where opportunities are. And as RANA, we have been struggling to get a formal engagement platform with Africa CDC and the national level Ministry of Health in every iteration of outbreaks. And we've been doing this deliberately because it's an opportunity for learning, and it's an opportunity to help, engage better with the biggest resource we potentially are not utilizing well, which are community frontline support systems. And civil society organizations like us work very closely with them. We have identified that there's an opportunity. And this is something that has been mentioned in a lot of policy statements without commensurate practical action in terms of implementing the intentions of utilizing communities as a frontline defense in our health security, apparatus. So really, what we would also want, and I have worked previously with your unions, for example, and I'm glad Mary Claire will tell you that part of this industrial actions that have been mounted by health workers union in Kenya, for example, have not been about them seeking salary raise. I know that's important for you as well, but it's about asking government, we are experiencing these challenges and we think there's a solution here. How can you help improve these gaps in terms of implementing policies that exist in terms of budgetary allocation, so that you also become part of the advocacy apparatus? You are a big source of the evidence that those of us working on the advocacy side can use. And I think we have an opportunity to work with you to help build a resilient health system. If you can be working very, very deliberately with civil society organization to be channeling back information in terms of the gaps you're noting in the systems and the opportunities that you're probably observing, so that they can know, where the gaps are and, use that information to help, advance demands for more progressive policy formulation, but more importantly, implementation, because we have quite a lot of progressive policies in a lot of countries. A lot of times they're just gathering dust. In Africa, we joke that we have commitments named nearly after every city in Africa, like the Abuja Commitment, Abuja Declaration, the Maputo Protocol, the Lusaka Agenda, the Accra Reset, the Addis Ababa Commitment. Every city nearly has a commitment. So we are not short of commitment. I think what we are short of is action that need to translate these commitments into policies. Africa CDC, for example, launched a very robust pandemic, preparedness and response policy together with the WHO that created all these RCCEs, the regional coordination centers, the public health emergency operation centers, very progressive initiative. But a lot of them, if you go to many countries, are still externally supported. They're not having domestic recourse. So those are areas where I think you people need to roll up your sleeves and sometimes join us on the streets to help, push for this agenda, so that you're not just signing death certificates. As I remember one time your colleagues in Kenya were saying, we don't want people to come to hospital and we can't do nothing with them. We want to be able to help them. And this is what we need to be able to help them. I think that kind of voice is very powerful. Let's continue. Continue to the next one. Yeah, so I think this one I will leave for you guys to change to deliberate. But I think for us, what should change after PHEIC? I think what should change should be before the PHEIC. We need to have trigger levels that are very remote, very at lower level. Somebody's unmuted. You could kindly mute. We need trigger levels that are early enough to help trigger action before we even reach the PHEIC station, the PHEIC phase, because I think the threshold is very high. But I think critical, in terms of what needs to happen after public health emergency is declared. I think is everybody, all stops must be activated. Every sector of the community. What we keep saying in a lot of theoretical in context, the whole of society, whole of government, is something we're yet to see in a lot of response. Whenever there's a public health emergency declaration, it's still a public health, it's just the health people who are concerned. And you wonder, how are the security folks working on this? How are the immigration border point, officers being involved? How are the community faith leaders? Because you recall in the different outbreaks that we've had in Uganda around Ebola, and I don't know if there's somebody from Uganda in this call. One of the challenges we kept facing was that people would resort to seeking help from faith healers, from traditional medicine people, before they even go to formal health systems. And that showed there's something that they are trusting, making them trust that side more than the government side. How do we involve those other actors who are likely to be the ones that people go to when there's an outbreak, and we let them be part of the response, not just people who are being exposed inadvertently because they're not even aware. When they're seeing a lot of people seeking faith healing, people seeking traditional medicine, there's something that could be wrong. So we need to really bring into life the whole of society, the whole of government approach, so that we can activate all points of response and use that as a launching pad for the next possible outbreak, so that we don't go to bed once that is contained. So I will leave that slide for you guys to deliberate. And, in terms of what really needs to happen after that, I think is having the capability to pivot on the first day, the day zero, and ideally, having resources that can be deployed immediately that an outbreak is reported is something that we struggled with. We need to have very robust predictive models, which is something we still struggle with. A lot of our surveillance capabilities are externally supported and are disease focused. We don't have disease agnostic surveillance systems. It's, we're currently having conversation around this currently in Mozambique, and you'd hear we have one around HIV, we have around surveillance around TB, we have surveillance around mortality surveillance. So we don't have systems that are tooled to be, to pivot and detect something new. And that is because our systems have very vertical focuses. And I think those are some of the gaps that lead us to these. And we should always evaluate and see after PHEIC, where did we miss the signal? How can we be better prepared next time? And what needs to change in terms of policy? What needs to change in terms of partnership? What needs to change in terms of coordination? So those are some of the things that I think are important. Continue to the next one. And Anthony, you're about to come in. So I think what we can share as a call to action, I think it's really everybody's responsibility. There's somebody who bears bigger responsibility, but there's somebody who bears even an equally big responsibility of making that other person do what they're supposed to do. I always say that we're the ones who have the responsibility to incentivize governments by making the right demands on them. And you who have, the biggest connection to the health systems, because when it fails, it's your new people. And a lot of times you get overwhelmed, particularly on the LMIC region, where it's one doctor to 10,000 people or more than, when there's a crisis, you lose your minds, you are exposed more than anybody else. I think it is in your interest, and it is in the interest of us who work on the society side to work collaboratively with you so that we can help, bring these changes that are important for our health security to be put in practice and to be resourced. So really calling on government, professional associations like yourselves, to work very closely with the community side, the demand side, that the frontline teams, including civil society organizations, so that we can institutionalize these lessons and make our society and communities better prepared to manage, to detect and prevent. I think that's our best bet. But in the event that we have an outbreak, manage them and contain them very quickly. I want to pause there and pass it over to Anthony if there's something he wants to share or any question from your end. Thank you.
Thanks, Aggrey. I think you've adequately articulated the engagement. I will let it to be more interactive so that if there are any questions, then I can weigh in. Thanks.
I will give the space to MC. Now it's a bit more interactive discussion. So MC and Aggrey, you can have a bit of live discussions as well. I will help sharing the screen.
Thanks, Aggrey, for that wonderful presentation. I think since you're leaving early, I could open the floor a little bit for anyone who has a question for Aggrey right now to ask it so that he can answer it and then leave us in a few minutes' time. Then we can proceed with the session questions that we had. So do we have any questions for Aggrey based on what he's presented? You can ask on the chat or you can raise your hand. We have a question from Wuna. How to overcome barrier to policy statement to implementation level from individual level, JDN level, WMA level, national and international level. So I don't know whether, Aggrey, you could give some advice on that. Then next we'll have Amira to ask her question.
So the question is how to overcome policy, just again,
How to
to bridge the gap
overcome between policy and implementation.
Yeah, so the gap between statements, intentions, and actions. I think that is the biggest elephant in the room. A lot of in my intervention, I mentioned that we have a lot of statements of intentions, very brilliant ones, that are never translated into action. And I think what we have come to realize in this space that health is as a political agenda as it is a technical issue, as it is a social and economic issue. But I think the most important element of it is political. And people who make decisions and who push for action to implement these policies are politicians. They need incentives. And incentives is if there's a political action, if there's a cost to inaction, then they will be compelled or they will be pressurized to do the right thing. A lot of time, health is depoliticized in many LMIC contexts. We see it as a political thing. It is individualized. And, a lot of times we own the challenges, even though they're systemic. And therefore, you fail to get adequate health. You blame yourself for not having the correct insurance or not having money, and you go home and wait for your fate. And we don't see this as systemic. And I think what pandemics and epidemics and outbreaks show us that really health is not an individual concern because you don't, it's not your failure that you have an Ebola outbreak, it's a systemic failure. But if we don't organize ourselves in ways that we can extract that political accountability, then we will have a lot of policies that have not been fulfilled. So my plea always is that let us find ways of politicizing health. I know they made the PS for Health in Kenya recently was saying, let's not politicize health. That is exactly what we need to do. We need to politicize health. There needs to be political cost of not doing the right thing, of not implementing the policies. And that's why I'm saying you people who are on the side where failure is very visible, And sometimes they blame you for something that is not your problem. They come to hospital and they're not able to get medicine. They say, oh, the doctor has not given me medicine. And they don't see that as something that should have been addressed at a different level. Or you're overwhelmed. You have like 100 people to see and you don't get to see them, and they blame you for not doing that instead of looking at what is happening. And if we own those problems and not tell them, you need to tell your local council member this, you need to tell your MP this. These are problems that need to be addressed and that require their action. Then they continue happening. So I think it's really extracting political action, political cost to this inaction, and pushing them to be able to do that. And of course, also mobilizing and engaging our constituencies to make these demands consistently. And when we have gaps, we make reports. I think there's a part where we talked about, like really creating a scorecard and having an accountability framework that can follow through what commitments have been made and what has been achieved. And if that has not been done, what do we do after that? So that's the political question that you asked. It's what will make the difference. Yes, Amira?
Thank you so much. Your presentation was very insightful. For my question, it's about something you mentioned that I personally saw in practice, which is that patients sometimes trust more traditional or religious healers or go to them first. So my question is how to balance that because we are tied to evidence-based practice. But as you said, they have an important role when it comes to outbreaks. So how do we, in practice, include them, or should we just monitor or evaluate post-pandemics or post-outbreaks, their influence on communities? How does that look in practice?
Oh, thank you very much. I think in this context, it's a social contract that we have. We build with our clients, the patients, who are also participants in their own health outcome. And it's not just about them being unwell and seeking help when they're unwell, but they have opportunities and responsibility to support this endeavor of staying healthy, using their trusted means of doing that. And communities tend to trust certain people, and we have to find ways of involving those that they trust to be part of the solution. And work with them as partners, not as adversaries in this scenario. I think there's a great opportunity to turn those faith healers, those cultural leaders, those community health workers as allies who will give them the right information. And of course, there are areas where somebody just needs that faith intervention. They can do that, but I think they should be supported to be able to triage. This is what I can help, but also, be cautious, because when the first point where people run to, they're also exposed. So I think we would need to work with them from their point of interest as well, that we are appreciating what you do and we value your role in this community as a trusted person. This is how we can work to keep you healthy, but also keep the community healthy. This is, when you see this, just be able to tool them and support them to be agents of delivering health and not seen as adversaries who are diverting people. I think there are instances where people can have, delayed medical seeking, practices that can lead to death, for example, where a woman needs to seek, qualified health clinicians' attention, while in the process of labor, and they choose to go elsewhere. I've seen that happen, and that delay creates, challenges that can lead to death. And we can help, reduce those delays by working with these same people to be the people who would say, like, when you see something like this, and get them. And I think there's always, I remember working in a context where we even translated religious interpretation, and then when you see it is God ordained, it is okay to seek medical intervention. It's still, and they become the people who will be directing and triaging people to your end and helping connect them to the formal system. And it's something that we have to build over time, recognize them, and make them part of the solutions and not a diversion from the formal. So it doesn't come easy. Some may be resisting because they are benefiting financially. But I think it's something that over time, if you get a few good ones who, become the influence of the positive deviances, we can influence a good section of them into becoming our allies and supporters. And I think that has happened in a lot of contexts. Yeah. So the fact I know we can't avoid them. So we have to make them our allies. Yeah.
Thank you.
Any question? I know I have to jump out now. Otherwise, Anthony is staying on and will be responding to any additional question. I just want to thank you all for being good listeners, and Mary Claire and Kevin for organizing this wonderful conversation. We really value the partnership between yourselves and advocates like us, because I think we have the same agenda, we have the same mission, and if we work more collaboratively, intentionally, I think we will achieve much more. Thank you very much. Nima, you can go ahead, but Anthony can pick that question.
Thank you so much, Aggrey, for joining and giving us your perspective and experience on the ground as well, which is very, 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 very useful for us, especially you're responding there on the ground, especially in Maputo right now. Nima, you would like to ask a question?
I see Nema said she'll ask her question in the chat, which is okay. We'll get to it as soon as she's posted.
Maybe if I could just add on Amira's question.
Yes, please.
I think from the recent engagement in the Budio Ebola, I think it's one of the demonstrations in terms of the interaction between evidence-based practice and community trust, and why we need to advance them together, and especially the stigma that comes even with the name, Budio being associated with the name of a place. Budio being associated with the name of a place and the linkage. Is my video visible?
You can see, yes.
Okay. And being associated with the name of a place and the sticker that comes with it, looking at it, a place, Budio being a place in Ituri, associated with DRC and Uganda, and the level being a source of infection, the punitive that comes with the language, and the excessive restrictions that comes with it to drive the outbreak. But looking at it, ultimately, the early detections of symptoms of the virus is through fever, fatigue, vomiting, and body pain. And these symptoms resemble malaria-like symptoms or other common ailments. And therefore, people may first seek care from traditional healers, from pharmacies, or informal providers, whom for me, I think they will trust more than rushing to the hospital. And it's common in most of our communities because in most cases, people try to seek a solution before they run to the hospital. And therefore, for me, I think the response will be in terms of how do we ensure the engagement with these traditional healers as we pursue the other evidence-based engagement in terms of medication and treatment. And that's where I think medicine, in a way, needs to interact with the society, besides the burden that we have in terms of the numbers that we have to attend to, and the issues around the gaps in health resources, and avoiding avoiding the challenges that come with it. So in terms of us providing that engagement that could allow, in terms of even explaining these diagnostic uncertainties and some of the value of early supportive care, so that communities can start trusting the formal systems, but not also negating the role of the traditional and indigenous structures that exist in terms of disease detection and engagement. And for me, I think the lessons that we pick more is that in most cases, stigma does not merely come in as a social consequence of an outbreak. But I think for me, it has some epidemiological risk. When people fear the response more than the disease, they tend to hide. And when they hide, I think it becomes a breeding ground to spread and expand the disease more, and sometimes becomes more difficult to contain and address it. And for me, I think therefore evidence will tell us how to control a virus like the Budubujo one currently, but trust for us in the communities and from the engagement we've seen. And even if you look at issues around COVID-19, which was one of the biggest public health emergency, one of the biggest pandemic we've had in the recent times, we see that communities, once they start determining that trust, they start making measures to control. And you go to communities and find a washing point at the front of the door that helps us to contain COVID. You'll find communities buying citrus, focused fruits that will help them to boost the immune system, and they are able to avoid going to the hospital. Thank you, and over to you.
Maybe I'd like to kind of like relate, because this is very relevant, the questions, and we're talking about community trust a bit later on, a bit effective, but Anthony highlighted what is the most important difference, I guess, between this Bundibugyo Ebola virus outbreak and the hantavirus that happened in the cruise ship. In the Bundibugyo Ebola virus outbreak, it happens on the village community level, which meanwhile, the hantavirus one happens on the cruise ship, right? So it happens very different. So how we are responding them is very different as well. And what I particularly learned from the news, I am not from there, but this is why we are interacting with these leaders in Africa, right? To learn and how to be able to bring those lessons learned back to our countries and our communities is like how are we responding to that? Because things like in the community in Budipugyo, Ebola virus is a lot of like I read a lot of like pushback from the community who do not believe that Ebola exists, because I think in the beginning there was some people who they do not know, and maybe was like too aggressive in some sense, probably. They cannot, which is also like the healthcare worker did not do anything wrong. Maybe we could learn from maybe better socializations or approach from religious leaders to learn more about that, most probably from what Anthony highlighted about the importance of that, because when we are not taking into account the social cultural context of that community, the community push back and they do not trust the healthcare leaders that are working in that community. I saw the news, which is very saddening as a healthcare leaders or as a frontline workers. There are vigilantes who are actually actively trying to hurt them, and some of them pushing them out, and they literally do not trust anyone. I think this is a learning experience that we need to highlight, that we can learn. What do you think, Anthony, or MC maybe, or people in the audience as well? I'll try to also like kind of like bring it to the questions of like what's different with the hantavirus and the management of the Bundibugyo. I think it's been great to see a lot of advancement. Even the Ebola virus vaccines goes to phase 1 now. There's a lot of like advancement that is doing there. I think a lot of like public leaders are doing great things, but of course we need to learn something that we can probably like bring back home.
I don't know whether, Anthony, you have a comment on what Kevin just shared.
Sorry?
I was asking if you have a comment on what Kevin just shared.
Sure. I think from RANA's experience, we've seen community trust not merely as an optional communication activity, and I think for me picking lessons from COVID-19 and how it affected some of the primary healthcare engagements, and I will pick experiences. I think we post COVID-19 we saw a lot of fallbacks in terms of immunization. And for me, I think trust becomes a very essential infrastructure for preparedness. Laboratories may identify viruses, but for me, I think when people trust systems, they start reporting symptoms, but they also start seeking care early and cooperate with the contact tracing and safe barriers. And I think we look at the experience we had with COVID-19 and how it was being handled. And I remember at that time I was working, I'm Kenyan, and by then I was working in Uganda. And you could see the stigma that would come with it if you travel and appeared in the village, even if you just drove yourself without making contact with anybody, the suspicions that was around it, and how people avoided to share information. And therefore, it became a bit difficult in terms of tracing contacts, or even if somebody went for a burial, in as much as it was restrictive, and you know how our communities sometimes attach to some of these cultural behaviors. For me, I think looking at the current outbreaks, I think it presents some difficulties in terms of the trust environment, in that the fact that we do not have an approved virus-specific treatment, and we have early systems that resemble common ailments, it affects more community facing, leading to a bit of insecurity, but also fragility in terms of services. And for me, I think in this context, issues around mistrust should not just be dismissed as ignorance, but I think they reflect some of the unanswered questions in terms of our epidemiological and failures in terms of previous institutions. For us, I think what we've been doing in terms of engagement has been in terms of pushing for more integrated systems that lead to surveillance and early detections, but also working with structures to strengthen the response in terms of ensuring early action and early detection and treatment. Looking at the role the junior doctors can play, I think from a frontline doctor perspective, and looking at it from a primary healthcare and universal healthcare engagement, I think there's some responsibility in terms of working with structures within communities so that we're able to boost intelligence that enables us reach broader primary healthcare systems, but also moving beyond and seeing how people can also trust the other surveillance systems that exist in terms of laboratories, but also emergency operation centers that will require some quick decision-making to turn around some of the services in the communities, but also ensuring around protection and credible feedback. My colleague spoke about the 717 model, which provides for us a more practical accountability frameworks in terms of detecting outbreaks within a shorter time, notifying authorities within 1 day, but also completing the essential early response action within 7 days. And for me, I think a delay should be examined with communities to identify and every delay within community, I think should be examined so that we're able to ensure communities identify the bottlenecks within trust, the transport, reporting and financing coordination mechanism, so that the model works efficiently, but the model is able also to respond to some of the issues that we are facing. Aggrey also mentioned issues around technology and how we can accelerate the pathway through mobile reporting or toll-free lines, which I'm seeing now working through Ebola, or WhatsApp channels and digital dashboards and social listening. End of last week, I think I was in Lusaka, and when I was coming at the airport, and for me, I think it becomes one of the failures of the system, in as much as the airline, the public health people at the airport who are monitoring indicated to have communicated through the airline. People caught unawares because it's an airport that I've used severally, and there are no protocols in terms of just people filling a questionnaire or declaring whether they have been in such places or such places. And therefore, for me, I think trust starts from that aspect of people having that access to information early, being prepared, not feeling like they're ambushed. Because when human beings feel misinconvenience, they tend to lie, because you don't want to get misinconvenience further. And I think, as I mentioned earlier, I think my experience in Uganda was, if you declared you've traveled out of the country and you had been to one of the high-risk countries, you'd be taken to a quarantine or to a 5-star hotel, which was more expensive for 2 weeks. And most people felt declaring was a bit costly, and therefore people will hold back. And therefore, for me, I think as we work towards pushing for a more efficient system that it detects early, but also protects the frontline workers, then we should also work towards ensuring that there are more integrated modalities that ensure that community platforms are more functional and feed into the formal and informal health systems. And for me, I think it requires more in terms of protecting community responders, ensuring a more operatable reporting system, but also ensuring multilingual communication representation in emergency coordination, so that communities are able to get discussions in languages that resonate well with them and resonate and they're able to understand, so that we don't lose much also in translation. Thanks, and over to you.
Yeah, that's very important. Yeah, thank you so much. And I'll go for MC to ask one of the last questions before we would like to, we're a bit conscious of time. Would like to go like last questions for 1 minute, and then we'll move on the questions in the chat box at the end, and then we will give some time for the reflective session part for everybody to hear in here to also answer the questions and be a bit reflective about it as well.
Yes, thanks, Kevin. So our final question is with regards to us junior doctors. Most of us junior doctors are frontline healthcare workers, and normally some of us feel that pandemic preparedness is primarily the responsibility of governments or international organizations. What would you advise us, Anthony, to encourage us to recognize the critical role that we already play in the health and the policy ecosystem? Thank you.
Maybe you can, Anthony, you can say like 3 things maybe within 30 seconds. What do you think that you would like to encourage us to learn or to recognize?
Sorry, I was speaking on mute. I think one aspect would be in terms of as Aggrey noted earlier, recognizing the need to break away from the silo of professionalism and also just trying to understand the indigenous or community and knowledge platform that exists. That because health-seeking behavior is determined by other things. And there are also social determinants in terms of seeking for health. And I think for me, that one helps in terms of early detection of pandemics before they occur. Number two, I think for me would be in terms of being more vigilant to the behaviors, if people are avoiding coming to also, like it happened during the COVID-19, and it could happen with other engagements, just being more inquisitive beyond the technical scientific ways of seeking for evidence and everything. And lastly, I think I'll quote one of the doctors I think I worked with at AMREF at one point, who worked for a remote district, and every time people will come with strange diseases, and they mounted an investigation just to try and understand what is it that was happening in the community. And through that, communities built trust in terms of just reporting beyond the surface in terms of the laboratory and the diagnostic bit of it, but able to give you a heads up in terms of if there's an impending pandemic or something. So you're also able to protect yourself from conducting or being able to respond and performing your duties in terms of the responsibility that are there, but also being able to protect yourself from an impending infection from the disease. Thanks.
Yeah, thank you so much for that. And it's a very good segue to this part of the more reflective space and interactive discussions. In this space, it's a safe space, so everybody feel free to also comment in the meeting chat or unmute. As Anthony said, it's a knowledge gap, right? But now we are trying to a bit maybe deeper dive and a bit more reflective on it. So knowledge has been lacking for us. So there's a lot of way for us to do and build our knowledge, right? But if you would say one thing, like I'm asking the audience here, if you would say one thing that we are lacking in terms of preparedness, what do you think is that? What kind of things that we have built a lot of different things? There's systems, there's community trust, there's a social and cultural competence, a lot of things, right? But in your opinion, and maybe you can also share a bit about what are you concerned about that, and what are you hoping that we can how we can bridge that gap, for example? Like knowledge is big, right? But what kind of knowledge that we need to, and that will hopefully help us to shape and learn about what we are lacking in ourselves, but also how can we shape, future capacity building events, but also how can we actively learn and, beyond our formal medical education system. I'll give you another prompt. As we have learned before that preparedness is also not it's also political and financial as well. So it's more than health. What can be learned, and what kind of advocacy priorities that should we champion to strengthen preparedness within our own country? So these are the two prompts that I would like to give space for the participants to reflect on. And feel free to raise your hand, unmute your mic, or even if you're not comfortable or unable to do that, put it in the chat and I will read it out for you. Amira?
Yeah, I'm kind of still reflecting on all the questions. It's hard to choose one thing, especially after the speakers, I guess, made a wonderful diagnosis. They mentioned so many issues and many tentative solutions. But I guess the thing is the verticality, which is that as frontline workers, we receive the recommendations, but there isn't maybe a clear organization on how to include us as formal partners that participate in the planning, that are trained to act early. And then there's also the other side, which is the political preparedness and the system that fails to include us and prepare us for such outbreaks. So yeah, I would change maybe the verticality. But the good news is that I guess networks such as the JDN or such like meetings are a great place to start in organizing all is too ambitious, but maybe a lot of junior doctors and frontline workers together. And maybe we should be more proactive and organize collectively, locally, nationally, and also globally, as we're doing here in JDN, and participate actively and advocate for our participation in planning and implementation.
Thank you so much, Amira. Such a deeply reflective, I think, response on that about the system is very vertical, as we see, because like if you learn about the IHR, it's like it goes with a lot of layers of how we notify things and so on, and we are probably the bottom of that chain, and it seems that maybe it's too out of reach, but actually it's so real for us. So it's more than about educating ourselves, but also, as you said, mobilizing change in the community, right? And one of the things that also like JDN do is also doing research, education, but also advocacy. And we would love for all of you to also be active with us, join our WhatsApp community, especially for the Preparedness Working Group, to be active there and shape things with us, because we need you, people like you who care enough to come here, who care enough about the subject matter, about resiliency and preparedness, to be able to mobilize the change in the community level. So it's not just about understanding them, it's about mobilizing the change. Anybody else would like to add on or build on that reflection? There's no right or wrong, so it's a very reflective space. What are the things that we can learn? What are the things that they are still lacking?
Maybe if I could jump in.
Sure.
Yeah, for me, I think for junior doctors, if you look at the previous public health emergency with international concern and the lessons that we picked, I think preparedness comes out not just as a responsibility of the governments and international institutions, but I think as junior doctors, you are often the first to see those unusual symptoms. You're usually the first to hear patients' fears and the first to experience failures in reporting, referrals, and in terms of even protective gear and essential supplies. But also, if you look at in terms of the frontline responsibilities, sometimes it's not matched with the protection, it's not matched with training, it's not matched with the decision-making power or some of the financing models that we have in our hospitals. And for me, I think you are frequently treated as implementers of policies, but you do not have to design those policies. For me, I think if I'll weigh in terms of what you asked for, some of the recommendations for your advocacy, one could be in terms of making outbreak preparedness a core part of the undergraduate trainings, internship, and continuous professional education for junior doctors and for me, other medical practitioners that work in hand with you. And number two is in terms of equipping junior doctors to recognize, isolate, report suspected cases through clear protected channels. And I'll continue stressing the 717 model to document the frontline bottlenecks in detention, in notification, and early responses. And ultimately, I think for me, will be how do we strengthen that strategic task that junior doctors have in terms of transforming the individual experiences into organized evidence, into collective advocacy, and institutionalized accountability. And I would stress, I think, the mention that Aggrey made in terms of how we've worked in Kenya with the KPMDU to go beyond just the motivation, but for them to go out and call for industrial action when they feel that as frontline health workers, their voice is not being heard, they are not well protected, and they feel sometimes powerless to a level that patients are passing on. So instead of them discharging patients, they are signing death certificates. Thanks, and over to you.
Thank you so much for the reflection as well. And I think it's and I recognize that not everybody are not comfortable to speak up. You are more than welcome to put it on the chat or reflections, and I will read it out loud as well, so we can all learn together. And that's how we're building this community, right? Who cares about this issue? So feel free to put it on, and I will try to slowly move away from that discussions and going a bit deeper as well on reflections on the equity and community trust. And I think this is very interesting as well, because like I see a lot of people from very different parts. I think at least there's people come and go, but I see there's like at least 4 to 5 regions here, like all across the world, which all have very different cultures and type of like social approach to things. And I'd like to prompt with this questions of what is meaningful community engagement means to you, and that is aimed to prevent misinformation, stigma, and avoiding punitive responses for communities. Like we learned that, for example, partnering with religious leaders in some part. I come from Indonesia, and from very early on when I was still a medical student, we learned the importance of mobilizing change with key opinion leaders such as faith-based and religious leaders to partner in immunizations, and how that will also Anthony talk about, and Aggrey earlier talk about how that will change the vaccination uptake, and that will help the disease, right? And probably also goes more than communications or building community that goes beyond just during if the outbreak happens, right? Fostering those communities. Like one of the things that I learned that I would like to share, for example, we have this system in Indonesia. We are creating this community health workers. We always do this, public health campaigns with them, communicating them and developing their knowledge, especially about their matters. For example, about dengue, there's things about diabetes as well, about nutrition. So it's different people, we call it cadres, or in English, community healthcare workers. And that's how we are building those, community trust, not just when the problem happens, but actually prevent them way beyond well before the outbreak happens. Maybe anybody else would like to share their experience or their reflection as well about meaningful community engagement. Amira?
If I may share about where I practice, which is in Algeria, the situation is a bit different because there is a big clash between informal caregivers and the medical practitioners. Like, they're not at all recognized as potential partners, on the contrary. And when all of this exacerbates during pandemics or outbreaks. So, but there are some institutional efforts to include sometimes religious leaders in religious places to raise awareness about health issues. But most of the time, it's kind of complicated to reconcile both of these populations that feel like antagonists most of the time. But I guess personally, I think I share your vision where there isn't one way of knowing, I guess. We could learn also from some indigenous practices. We can evaluate, we can include anyone can be a partner, I guess, if it's done in the right way and planned the right way. So, yeah.
Thank you so much for that. And it's highlighting the difference between countries and regions. I think how sometimes those divide actually, how can we as a frontline healthcare workers try to bridge that divide, right? Between this informal and formal. So it's not just classing, but they actually can work together in harmony in order to build and foster this this equity and this trust within this community. I think that's one of the most important take home that from your from your sharing experience as well, Amira. Thank you so much for that. Anybody else who are here?
I think I'd like to chime in a little bit. You find many a times doctors are the gateways to health information. So you find especially communities trust their healthcare workers, especially the community health workers, with empowering them with the right information and the skills on how to handle pandemics. And I think there has to be an element of synergy between all these moving parts, from community to healthcare work to junior doctor to whether it's a nurse or a pharmacist. There has to be that intersection or that collaboration in the initiative, because what the community health worker sees and reports to the doctor is largely shaped from what they feel, see, and observe in the communities. So I think there has to be more investments in health workforce, especially those ones who are close to our communities, because most of these community health workers are actually volunteers. They don't have a stipend or any source of livelihood, and that puts their job security at risk, and sometimes also affects their motivation for doing the job that they have to do, which is so pivotal in primary health care. Yeah, thanks.
Thank you so much. And I'll slowly go to the closing as well. And before that, I read out Sarah said about it is great that community are able to help each other and not solely depend themselves to medical practitioners. But perhaps the biggest challenge is how fast the knowledge exchange can reach more rural populations. I think one of that idea is like it shouldn't just rely on the frontline healthcare workers, but the people in the community and how we can increase those health literacy beyond the healthcare practitioners or the people who works in healthcare, right? And we slowly try to conclude, I would like to close. We already asked that questions about community trust and so on. Maybe before we leave, I would love to invite you to kind of like have this a bit of like just last thing before you leave, write one sentence in the chat. And this would be just skip here. I wouldn't read it out loud. But I will give you space, just maybe like a minute. In the next 30 days, I will strengthen outbreak preparedness by. I'll give you 1 minute to conclude that. So we can translate that to our own commitment so we can learn. I would love for you to make that own commitment as well. So it's not just learning and listening about lectures, right? But about, okay, now what we are going to do. What's next? Thank you so much for sharing that.
Yeah, so I see Amira has shared. In the next 30 days, I will strengthen outbreak preparedness by taking courses or trainings on the topic and organize with fellow passionate. Sorry, my screen has just gone blank. Maybe Kevin, you can wrap up the message for me. Fellow
Yeah,
passionate.
it's about passionate colleagues, meaningful advocacy efforts. And thank you so much for that. Anybody else would like to share theirs? Gio?
Yes, thank you. So, I'm opening my microphone not necessarily to continue the in next 30 days pledge, but I want to circle back to what Anthony has said about how junior doctors feel hopeless when the pandemic happens. And for a lot of us, like our first contact with the pandemic was during the COVID-19. Before that, maybe we were not doctors yet. And right now, we already have data that the average of a pandemic happening is like between 10 to 30 years. So by the time a pandemic happen again, we may already move on to more professional levels in our careers, and it might be our job to mentor our future junior doctors, our juniors, to how to prepare themselves for a pandemic. So I think it was somewhat an unfortunate but good learning experience that for some of us, we live in an era where we survived COVID-19 and we can learn more about it right now. And because I was involved in like surveillance programs during the pandemic, what I learned was that empathy goes a long way to prepare the communities for that. For example, not all people can afford to self-isolate. Some of them might still need to work and they cannot stay in their homes for long periods of time without any income. So when we spend time to talk to these communities and bring these nuances to light, then the community might actually have a solution to these problems. For example, convene they can convene and help each other to overcome this. And also we right now some countries including Indonesia have community health workers that can bridge the gap between primary health doctors, primary care health workers, and also the community themselves. And I also heard about religious leaders, and in some ways it was also implemented in Indonesia. So there are a lot of things that we can do. And for us who are who may feel that we are still in the junior levels of our careers, it might be a good thing because there are a lot of things that we can learn now, and then we can implement it in our careers to prepare for 10 to 30 years time in the future. So maybe that's it.
Thank you so much for that reflections about empathy goes a long way. Indeed. And I think that's the most important thing that maybe we forgot in our day-to-day task as a frontline healthcare workers just to keep diagnosing, doing stuff. But then it's not easy, especially during the pandemic or during an outbreak that happens. But I think that's a very interesting thing. Thank you so much for sharing as well. I hope that I see several people in the chat are sharing their pledges as well in the next 30 days, so we can move this from motivation, knowledge into action, hopefully. And I would like to close the session by sharing this. One of the MOOC that I learned from as well. If you would like to learn more, this is a very interesting MOOC from WHO. There's several MOOCs that you can learn from WHO. In particular, I would like to share this one, the Introduction to International Health Regulations, through that link. So feel free to do that. It's just like half an hour to 40 minutes. You get the certificate after that as well about what is IHR, how does that operates, and it gives you a bit of like daily cases, like updates and stuff, and then it changes, and it's very interactive way of us learning. And then you don't have to read the whole IHR. You actually learn it step by step by engaging with the platform, and it's very, very, very interesting and easy way to learn about what is IHR. We touch upon that. It's very technical term, but it's very important for us about how are we notifying, and what happened if we are the frontline healthcare workers in that community, and so on. So feel free to use that resources. And I see some people also sharing their pledges in the chat. Feel free to do that more. I'll conclude with this. I would love for everybody, we are a bit over time, apologies for that, but thank you so much for joining. I would like to invite every one of you to please come in the JDN WhatsApp community. It's a networking, knowledge sharing, and so on. And hopefully, I know MC is already trying to invite another speakers, I heard. So we would love for all of you to, it's still TBD. We will try to announce them if we already have it, hopefully in the next 1 or 2 months, to do similar things with maybe different focus as well. And somebody from the chat also highlighted about the needs in Eastern Africa as well, which is very important. So please feel free, give an idea, co-design it with us. We are very open to that. Please do it with us. And thank you so much as well for Anthony, for your offer to strengthen the regional advocacy to engage with Africa CDC, National Medical Association, and so on. We really appreciate that support, and hopefully we can strengthen them. And this is just a start, and we can keep strengthening not just advocacy, but also our knowledge, and also hopefully our research. We have 1 or 2 ideas about the research that we would love to do, but of course we need people that are actively engaging with us. So please reach out, join the group, reach out to us as well, personally to MC or me, as we are the co-chair for the Pandemic Preparedness Working Group. Let's co-create something together. It doesn't always have to be all like MC or me, becoming the moderator, for example, or becoming the main person for the webinars. I hope that you can also co-create things with us, share things, open up more networks in your respective countries or or regions, so we can mobilize change together to better prepare for the pandemics. Thank you. So I will conclude the sessions. Please scan, take a screenshot on this working group. I hope that all of you shared, and thank you so much for everybody who are joining this session. Thank you so much. We really, really appreciate your time, for taking your time, half an hour, and yeah. Let's take a short picture before we move on then, if you guys can.